Good afternoon, and welcome to this month's Institute for Health Policy Studies Health Policy Grand Rounds. I'm Joanne Spetz, and I am really pleased that we have Ninez Ponce here today from UCLA. Ninez is a professor in the UCLA Fielding School of Public Health, and she is the director of the Center for Health Policy Research, which is a center with which we do a lot of collaboration here, and they do some excellent work. She leads the California Health Interviews Survey, which is the nation's largest state health survey, and is recognized as a national model for data collection on race, ethnicity, sexual orientation, and gender identity, and immigrant health. If you have never been on the website about the CHIS, I strongly encourage you to go take a look. There is really some very, very rich data there over a long period of time. It is just a fabulous resource. So Dr. Ponce has done a lot of research with those data, and she has served on the board of scientific counselors, National Center for Health Statistics, and on committees for the National Academy of Sciences and the National Quality Forum, where her expertise is focused on setting guidance for health systems in the measurement and usefulness of race, ethnicity, and social determinants of health data to monitor health equity. I could go on and on about the numerous awards that she has received, but I really don't want to take away any more time from her presentation. So Ninez, if you are ready to share your screen and flip on your camera, we are ready to go. It is great to have you. Thank you so much for taking the time.
Thank you so much, Dr. Spetz, Joanne. As you said, I do feel that the Center for Health Policy Research is a sister center to your center, and I see from the participant list many friends and collaborators that have joined, and hopefully some new ones so they can hear about this survey, but also some of the work that I'm doing on health equity. So I'm going to share my screen now. And
great. And while you're popping that up, I will note to everybody that the Q&A option at the bottom of your Zoom screen is open. So if you have questions, please put them in. I'll be keeping an eye on the questions, and if we get a bunch of them that come in partway through the presentation, we'll take, I'll interrupt Ninez and get some questions in. And definitely at the end, we are going to make some time for Q&A. So please do put your questions there or observations. You will notice that we don't have a chat function going, so use the Q&A box, please.
Great, thank you. So my talk today is No Equity Without Data Equity. It's actually a talk I've been doing the rounds in not just UCSF, but some other spaces. For example, states like Colorado that are very interested in transforming their public health data systems, not just the survey infrastructure, but also with surveillance, particularly the COVID data, and being more responsive to the populations that they purport to represent. And so my argument is that with all the discussions on health equity, that a foundational step is data equity, and I'll talk about that in this talk right now. So my overview is to talk about the role of data and data equity, some examples of, I think, what many of us know here in this Zoom room of the data failures during COVID-19 and in general, particularly on race, ethnicity, but also on other aspects of data on occupation. I know that Joanne works a lot on that, but on some of the hospitalization data and infection data, so the imperfections of this data and also the slowness in getting this out to instigate an appropriate public health response. I will focus though on race ethnicity data disaggregation, and there's two examples besides CHIS, but I wanted to talk about two organizations and programs that were born out of the need for better data, particularly at the beginning of the COVID-19 pandemic. And this is the Native Hawaiian and Pacific Islander Data Policy Lab, which is now housed at the Center for Health Policy Research, and a new nonprofit that I started with actually some very eager, very emerging leaders, young Filipino professionals, health professionals, and it's called the Philippine XAO Community Health Association. Then we'll get with Q&A. So I live in a space of, I'm a data producer of surveys, but all the insights, of course, are not just from surveys, although, of course, they have a special place in getting at what people are experiencing beyond, just getting access to care. And so EHRs, registries, claims data, COVID case and death counts, but increasingly, I'm appreciating about the storytelling, the testimonies, the lived experience, and also a lot of the media hits. The pain that segments of the population were experiencing were revealed actually from the media, very early on during the pandemic, because they were hearing it from stories, they were hearing it from the community, and particularly the Native Hawaiian and Pacific Islander community. They were hearing it in the communities. There's this one funeral home in the Inland Empire that there was just a lot of congregation and early deaths that weren't being registered in the surveillance data. So I do think that, when I think about data, that it's a broader view, although I live every day on making sure that the California Health Interview Survey is as respectful and as high fidelity and ear to the ground as possible in providing insights to researchers and to policymakers in California. So CDC defines or looks at health equities when everyone has opportunity to be as healthy as possible. And there are three roads or pathways to get to this health equity: programs, policy, of course, but in the middle road, and this is the road that I'm usually on, is measurement. And so the measurement piece, which is the data practices to support the advancement of health equity, is absolutely important. Data equity is part of the infrastructure. And so measurement is key to achieving health equity. But what I've said is that this measurement road cannot just be in the vehicle of academics, that there has to be some stops along the way where stakeholders are valued and are brought in terms of the design of measures, and not just the dissemination piece, but dissemination piece is key, but also in the design of what emerging public health issues do we really need to measure and how to measure it. So I also want to think, I believe there may be some folks here in the audience that CHIS is stakeholder engaged planning in terms of questionnaire development and sampling, and that many scholars from UCSF have helped us along this measurement path. But, the data, of course, doesn't just sing for itself. So data is there to uplift marginalized communities globally and locally. And the data is available, if it is available, would measure the health disparities that exist. And so the differences in health outcomes that are experienced by socially disadvantaged communities or populations. But it's not just looking at the health outcomes, but what are the drivers of these health outcomes? And so increasingly our field is trying to get at this measurement piece on structural inequities, which acknowledge that some of these outcomes are produced generationally, historically, by the distribution of power, income, goods, and services. And race ethnicity is the focus of my talk today, and the focus of measurement, race ethnicity measurement, and also language is the focus of my research area. But the social determinants which go beyond, race ethnicity, but the circumstances of people's lives and their access to healthcare, schools, education, the livelihood, the conditions of the places where they work, the places where they live, assuming they're housed, and communities, towns, and cities. And so all of this we care about as public health professionals, as information producers for policymaking, to ensure that everyone has a chance to lead a flourishing life. So data equity is, my definition is that data are collected, they're analyzed, interpreted, and distributed such that marginalized communities have say, and I said in this whole production process of data, from the design, the access, and the use of these data. And I'll be giving some examples in this talk. So the first story is the California Health Interview Survey. I think this is what keeps me most up at night, but it's actually pretty streamlined. So it's not as much as it was early on when we were producing this in my career. But I do say that, before I was a professor, before I was an academic, I was an advocate for a nonprofit that was based in San Francisco. It's now in Oakland. It's the Asian American Health Forum, now called the Asian Pacific Islander American Health Forum. So at that time, this was back late 1980s after the Heckler Report, where they looked at Black and minority health. And so it was a landmark report. But that report at that time showed that Asian Americans were following this model minority, this model of health, with having the least excess deaths compared to the other major racial and ethnic groups. So my task as an advocate at that time, so it's more than 30 years ago, was to come up with a data strategy on getting at data disaggregation. So I do say that my time as an advocate made me a better data producer. But I do tell people you don't have to be a data advocate to the creds for that, for being a better data producer, but definitely listening to communities helps. So the California Health Interview Survey for me was really my first job at UCLA back in 1999. I was not hired by Rick Brown, who was a founder of the Center for Health Policy Research and my late colleague. But there was something in the works in the room next door about this new survey. It was going to be like the National Health Interview Survey, but it would have sufficient sample in California so that we could produce insights at the sub-state level for the large counties, the medium counties, and the smaller counties that we would group. And I wasn't hired for the CHIS. I was hired to work on another project on health insurance, but I had heard about it and I crashed the party, I crashed the room. And because I was, I had put out the kind of the game plan on how to get better data, disaggregated Asian American data, and was very interested in what kind of plan the CHIS would be doing. So it is, as of today, the nation's largest state population representative health survey. It is continuous. We collect annual data. We are in the field every day until we finish data collection in a given calendar year. And it is, I'd say it is the most comprehensive source of health information on Californians. We want to be comprehensive, but we don't want to be everything for everyone or overburden the respondents, but we do ask a lot of questions. It's about a 40-minute survey. It is now on the web. 90% is on the web. It's address-based. You get something in the mail with a link, and we push you to go to the web and take the survey on the web. And if you, for whether it's by preferences or whether it's constraints by having a computer or low bandwidth, then we do have a phone number for you to get a telephone interview. And then if you don't respond at all, then we follow up by having telephone interviewers calling you. So the telephone interview on average is about 40 minutes, longer for in language. I'll talk about the different languages in another slide. And then in terms of the web responses, about 30 minutes if you do it by web. And I know some of you, and if you are a respondent, thank you, by the way. If you did respond, thank you for responding. And I also know that there's a lot of researchers who take the survey, and I do get a healthy amount of mail on how to, why didn't you ask this? Or, these are interesting questions, or, you could have asked this a different way. So we do take that all in consideration. We do have researchers and communities, partners and advocates. They rely on population-based survey data. And so I do think that more so than other healthcare data sources that I described earlier in terms of, say, EHRs, claims data, is that population health surveys do ask about the living conditions, education, occupation, income, trauma history, piecing together this backstory that may explain the racial and ethnic inequities, and who gets access to timely care and what the health outcomes are. So our two main objectives, as I said before I crashed this room when I was hearing them talking about a survey, was they were talking about that time, Rick and our colleagues were talking about the objective of this providing sub-state local estimates, but and a little bit about health disparities. But when I did get offered by Rick to, maybe you should be part of this and you can be a co-I, then I really pushed that the survey also have an explicit, specific aim of not just sub-state local estimates, but to measure health disparities in the state. And the health disparities in the form of the social stratification that we observe in the state of, and nationwide, by race, ethnicity, by language, but also by sexual orientation, by gender identity. And California, a quarter of our population are immigrants. So looking at citizenship, immigration status, and as we know, a lot of the public programs are based on eligibility of being lawfully present here. So we do ask a question about whether you have a green card or not. So we do ask some sensitive questions, but we frame it in a way that we say we don't work for immigration services, that we will, this is to get insight, this is to help ensuring that the needs of Californians, all Californians, are met. We get at disability status. I do think that we should do a little bit more on disability status, and then educational attainment, occupation, and income. So a host of questions, plus we geocode. So caring about context then can be linked to external data sources like environmental data, air pollution data, healthcare market data. So we can link, the CHIS data with other data geocoded to now, since we're address-based, at the address level. I think there has to be an explicit goal or aim in centering equity in population surveys. And we do have that in CHIS. And there also has to be an explicit process of co-production by community-based partners. And we do it, in a way that may not be as deliberative in terms of community engagement. It may be more consultative, and as our relationships evolve, as trust evolves, that it could be more focused in, again, this from design to dissemination, with working with specific communities. But right now, we do it through an advisory process, and then we have work groups. And again, for those of you who have taken part of this planning process, again, I thank you. We do have a work group on the adult survey, the adolescent survey, the child survey, and then another another advisory committee on multicultural issues, as well as a survey methods and statistics technical advisory committee. So I do think that if you've got the organizational commitment, you're accountable to the community, that health surveys then could have the equity objective, front and center. And when I give this talk to some groups that are, where equity is not necessarily front and center, I've given also these talks to industry, is that it's that actually then the quality is better. So there's the equity goal. By having that equity goal, by having that precision in getting at the different stratifications that we have in society, that actually then we ensure that policies are targeted to specific groups and their needs. And so quality is better, and policy making then becomes more both effective and palatable. So how has CHIS then have impacted data equity research? We have, I focused on the Asian American and Native Hawaiian Pacific Islander group, and I can talk, from Q&A on that group or other applications to other groups. But it does stem from these factors, is that we collect health and sociodemographic information for Asian and Native Hawaiian Pacific Islander subgroups, as well as the Latinx and American Indian Alaska Native tribal affiliation, sexual orientation, gender identity. And in 2021, we started a writing categories for white and Black African American. We do subscribe to the OMB recommendations, which is 5 major racial groups and the Latino, Hispanic, ethnic overlay. But I remind everyone that that's just a floor. So that's the minimum requirements. And then we go beyond that. The reason why we did white and Black African American writing categories was that we were ready to go into field with the Middle Eastern North African category, but because CHIS is weighted to control populations, and since the census then Census 2020 decided not to go with a MENA separate category, that our decision then was then to try to get the MENA subcategory, but still have weighting control totals from the census. So we kept the white and Black African American. So CHIS uses oversampling for the Asian American, Native Hawaiian Pacific Islander data collection. And we also have some American Indian Alaska Native oversamples, not every year, but in the census years. And then we've had some Black and Latinx oversamples in some areas in the state. We actually don't really need to oversample the Latino population because it's a sizable population, sizable segment of Californians, but in some areas that we have oversampled. So CHIS conducts interviews. We conduct in a number of Asian languages. When we were doing telephone interview, we did Cantonese, and we still do for segments Cantonese and Mandarin, but with written, it's Chinese, also with Korean, Vietnamese, and Tagalog. And we've done, much to the consternation of my survey research team, we started getting into non-probability space recently, where we've conducted a special tobacco survey on 2 groups where it's not well represented in a population-based survey because of small numbers, and that's for the Native Hawaiian and Pacific Islander group and the LGBTQ group. And I can talk more about our foray into non-probability space in Q&A. For the work on the Asian American and Native Hawaiian Pacific Islander population, I like to show this slide where, if you build, they will study and insights will happen. And this slide shows, starts from 1988, which is a little bit, or pre-1988, so mostly after the Heckler report on the Secretary's report on Black and minority health, and it goes through up to 2018. But I also put in some key legislative milestones or congressional or executive milestones that helped with building this infrastructure of disaggregated data for Asian Americans and Native Hawaiians and Pacific Islanders. One of them was in 1990, the Asian Pacific Islander Health Improvement Act, which established that the National Center for Health Statistics report on subgroups on Asians, and that was sponsored by our very revered Deer Lake leader, Secretary Norman Mineta from San Jose. And then in 1992, because of that act in 1990, that the NHIS National Health Interview Survey subgroup data started to occur for Chinese, Japanese, Vietnamese, Filipino, Asian, Indian, and Korean. And then the revision of the federal standards for collection of race ethnicity from the Office of Management and Budget in 1997, which mandated that you need to separate Asians from Native Hawaiians and Pacific Islanders at that time, as well as that multiracial categories that you can select more than one race. And then there were oversamples, and then 2010, the ACA, section 4302 in the ACA has a provision that actually has a more expansive set of Asian and Native Hawaiian Pacific Islanders beyond OMB. And there was an NHANES oversample for the first time in 2011 for Asians, and in 2014, NHIS actually had a special survey, it's a standalone survey on Native Hawaiians and Pacific Islanders, and word on the street is they might do it again. So there are these handles, but nothing really much was happening until like around 2001, 2003, you start to see the tsunami effect of greater PubMed studies on and here there's different colors because there's Asian only, Asian subgroups, NH or PI alone, or NHPI with Asians. So regardless, we're seeing then this increase. And it does show then that you do need to have guidelines, you do need to have some legislation, but you have to have, oops, something occurred here. Looks like I just, I'm going to have captions now. But you also need to make sure that there are data sets that are available. And in about the time when we start to see the tsunami effect was the time when CHIS came on the scene with collecting disaggregated data. So not causal, but we did look at the set of studies that were the drivers of this increase. And about 60% were from CHIS. So the highlights from the 2020 CHIS, and the 2021 CHIS is going to be available at the, hopefully by the first or second week of October of this year. So we collect data for 1 year, and then we release it to the public about 9 to 10 months after. So this is the 2020 data that is currently publicly available. And we shifted very quickly in 2020 with the pandemic by adding a COVID module. And the details of that are documented in an American Journal of Public Health article in December 2021. But we started asking about vaccine at that time. When we started about May of 2020, so asking about vaccine, if it was available, would you get it? But also questions about reduced job hours and income, if they were essential workers, and looking at mental health and psychological distress during the pandemic. So we started, actually releasing sub-year data during that year because we knew that there was, really this thirst for getting evidence, and how do we relieve Californians of some of the hardships, a lot of the hardships that they were experiencing during the pandemic. Also at that time during the pandemic, there, we saw the violence, and we particularly against African Americans, and also in the Asian American community. and a question on race, ethnicity, unfair treatment during the pandemic. And we did see in California that Black African American adults in California had reported the highest proportion of experiencing unfair treatment due to their race, ethnicity during the pandemic, followed by the Asian American population. And the result then of this treatment being unfairly treated resulted in we were able to link it to questions interests on mental health and suicidal thoughts, suicidal ideation, and likely serious psychological distress, and saw that it was heightened if a person was unfairly treated due to their race, ethnicity. So we also worked with, and something that I've been thinking about lately is, a lot health services researchers, we sort of kind of stay in our own lane, talk to other health services researchers, but we started collaborating with other departments at UCLA, particularly the Asian American Studies Center, which is part of the Institute of American Culture. And we thought, well, let's, after the Atlanta shootings, we started thinking about, well, maybe we should look specifically on Asian hate and incidents of that from a population level, just because what's registered is at the point where who registers a hate incident and what is considered a hate incident and who has the propensity and the willingness to report. So it could be hate incidents then could be underreported, but you can get it from a population level. And we thought just would be one way. So we collaborated with scholars from the Asian American Studies Center who had, where their scholarship domains are on looking at racism and unfair treatment. And so we looked at the impact of COVID-19 on Asians and Native Hawaiians and Pacific Islanders. And we saw that, this is in 2020, that 6.8% reported directly experiencing a hate incident due to COVID over the last 12 months. But we also asked about witnessing. And witnessing is really important because then from this, there have been community groups that have put forth bystander training if you witness. But witnessing, like 1 in 4, so 25% of Asian and Native Hawaiian Pacific Islander adults in California witnessed some unfair treatment or hate incident. And hate incident we defined as physical abuse, verbal abuse, and cyberbullying and other, but it's with several write-ins, but mainly physical, verbal, and cyberbullying. So 1 in 4, if you think there's about 6 million Asian Americans and Native Hawaiian Pacific Islanders in California, 1 in 4 is 1.5 million. Again, really becomes in this population crisis for this group with attendant associations with mental health. I do have a paper that just got accepted, will be coming out AJPH, where we link witnessing and experience a hate incident with severe psychological distress, with foregone care. We had heard stories from community health clinics that particularly those serving low-income Asian Americans, Asian health services in Oakland, California, that many of their patients weren't coming in because they were afraid to leave their homes. So we saw that the experience or witnessed a hate incident was significantly associated with foregone care, and also with increased perceptions of unsafe neighborhoods, so the neighborhood safety piece. So I think that, that just then as a population survey is a good tool to get at these measures of structural inequities. I do want to say that we have new measures. So for those of you who are waiting for CHIS in 2021 to be launched in fall 2022, is we have measures now on adverse childhood experiences. We have measures on positive childhood experiences. We have measures now on experience due to wildfires. So again, it's evolving content of a population survey that could be linked to health outcomes, healthcare utilization, outcomes, affordability of healthcare. So now I'm going to pivot. I just want to make sure I'm okay with time. I'm going to pivot to two initiatives that I helped launch during the pandemic. And the first is the Native Hawaiian Pacific Islander Data Policy Lab. I also want to say that in terms of data disaggregation, I think more and more organizations, data leaders are buying into, yes, we need to do more data disaggregation on race, ethnicity, but what's the how? How do we do it? So we do have a project at the Center for Health Policy Research on technical assistance on data disaggregation, and in early fall, when the grant gets signed, we will be starting a new national data equity center at the Center for Health Policy Research that will provide technical assistance on aspects of data equity, not just race, ethnicity data disaggregation. So my second story is the NHPI Data Policy Lab. So some of you may have caught this, and I know you've emailed me, but we just got recent play on the PBS NewsHour on inconsistent data that masking the toll on the Native Hawaiians and Pacific Islander community in the United States. And specifically, they featured Melissa Leyland, one of the leaders, actually she is the leader there, in Arkansas, the Marshallese community. And so about March, April of 2020, she had reached out to me and was already hearing all the stories of many Marshallese getting sick from the Tyson chicken plants in Arkansas, and unfortunately, more and more funerals that she was attending for this community. And how do you get, but yet the Asian Pacific Islander group were aggregated as one, and NHPIs were not separate. So the data wasn't showing that there was higher risk, because for the Asian community, they were seeing the same kind of losses that the NHPI community was seeing. So we worked with her, and anyway, that's the story of how we started this lab. And we started scraping data from different places, not just Arkansas, but in different states. Like we were scraping data from Utah, from Oregon, from Washington State, as well as Hawaii. But Hawaii does a pretty good job of data disaggregation, and different counties in California. So we thought, well, we were kind of doing this on demand, and then we decided let's launch a dashboard so that updated weekly, similar to the COVID race dashboard, which is brilliant, and so similar to that, but really focusing on the NHPI community. And so this is just a scrape of one of the products of this dashboard, and just that it shows, and this was a few months ago, so this isn't current, but just to show that we looked at the 9 states that had the high case rates per 100,000, and the orange line is the Native Hawaiian Pacific Islander community. And you see kind of this consistent story. So it wasn't just Arkansas, but we were kind of seeing this, and this is it continued through up to 2022. This increase, this higher case rates for Native Hawaiians and Pacific Islanders. We also have this for death rates. So then we looked at California too, and this was through getting restricted data from California, where the concern was, although California does disaggregate NHPIs from Asian, that there wasn't a disaggregation within the NHPI community. So we got access to restricted data, which California does collect, and then computed death rates per 100,000. And you see that what's driving the NHPI death rate of 100, this is in 2020, all calendar year, 123 per 100,000, not age adjusted, that it was much higher than the state total of 84, but also the Samoan community really had super high rates that weren't being seen also in the aggregated data. And then I also just show this counterfactual. Well, what if California, what if California followed about 24 states in the nation that aggregate Asian and NHPIs, and it would look like then 75, which is lower than the 84 per 100,000. And then again, completely masked the risk of what the NHPI community was suffering during the pandemic. So the recommendations are to follow the OMB guidelines, which is that they should be disaggregated. And again, it's a floor. And right before this talk, I just got a missive from OMB that they're going to open up comments on the revisions of OMB standards. And the decision to balance in just reporting, and again, this could be in Q&A, because I get asked this a lot. Yeah, you can split and split and split, but there's going to be some statistical reliability issues. There's going to be disclosure risk, and so just practically you can collect, but there's going to be disclosure risk in reporting. So my recommendation is actually, luckily for CHIS, we're every year, so you can pull several years of data to get a more robust sample, but you can also aggregate into intermediate categories. So for example, for the Asian category, you can look at East Asian, South Asian, Southeast Asian, and for the NHPI category, you could look at Micronesian, Polynesian, Melanesian. So these categories then would be of utility and much better than an aggregate category, particularly in designing programs and interventions. And lastly, what keeps me up at night is the Filipino. What was happening was I was working so much on the Native Hawaiian Pacific Islander community that I was getting lobbied hard by my colleagues and also my family, my aunties, most of them who are nurses, saying, "What are you doing? You're like, we're losing lives, every day." And in fact, the very first COVID-related healthcare worker death in Los Angeles County was a Filipino nurse. And then I also met then some advocates working in this space. And this is they're in the labor movement actually, and they created their own website called Kanlungan, and it was a crowdsourced memorial to the fallen healthcare workers in the United States, as well as globally, and most of them were nurses. But it was a memorial, and they did it all on volunteer basis. They did it crowdsourced. They looked at GoFundMe. They looked at Instagram. They looked at Facebook. Anything that had to say "born in the Philippines" or legacy.com that would say "we love that she cooked lumpia," or they were just scraping data that way just to create a memorial, and actually was our only source of data for a while until we started. Unless you got a restricted access data, which this is something that I did get, where we see that among healthcare worker deaths in California as of 11/5/2020 at this time, was that if you look at all other Asian, you see it's that COVID deaths are lower than the population representation. But when you look at Filipinos, that the COVID deaths are way higher than the population representation of healthcare workers in California. And then we also saw this in, I don't think I have it here, in another special study from National Nurses United, very similar, like about 4% of nurses, working nurses are Filipino, but over 31% the share of deaths of these nurses. So of this nursing population nationally. it's a JM Help Forum where we just kind of underscore, again, this restricted data insights of the disproportionate toll on deaths of healthcare workers in the Filipino community. But you can't get at that from public-facing data. I mean, you've got to get restricted data, or you have to have special sources, or you have to do what my now colleagues from the labor movement did, was do these crowdsourced elegies. So community engagement, very important. Once we started gathering all this information, we started, so that this group tends to tilt on the younger demographic. We started doing a podcast and getting information and also mitigating misinformation on the vaccines out to the community. I do believe that a lot of knowledge production is building the pipeline, and this is one of the members of this Phil Cha organization, Melanie Sabado-Liwag. She's a professor at Cal State Los Angeles, and she led this article in a recent issue on racism and health, again, talking about talking about the Filipino community and talking about the interlocking relationship between colonialism and racism, and how that manifests in both higher proportion of diabetes, heart disease, but yet higher proportions of representations in the healthcare workforce. So I was on the commission to transform public health data for Robert Wood Johnson Foundation. It was a good commission, high level, about I think collating all of the insights and elevating it to a commission with these higher level, that you do need to tell stories, you do need to prioritize governance of data infrastructure and absolutely put equity in front. And you do need to ensure that it captures structural racism and other inequities. But the how, again, is still has to happen, which is why we're going to start with this Data Equity Center to get more at the how. And then lastly, from a national policy piece, this is a moment where, and we got to seize it, where the White House, the Equitable Data Working Group was formed. That was out of the executive order on advancing racial equity to support for underserved communities through the federal government. April 2022 was the latest report issued by this group. These are the highlights of how they want to move forward. I'm very happy to see disaggregated data is number one, or maybe I made the table this way. Well, disaggregated data is definitely the one of the top pieces. And in reforming OMB or updating OMB, and underused data also, they want to encourage underused data. They thought more about administrative data, but I think that also gets at it's underused in some ways because there's such a high transaction cost. Like, for example, to get an American Indian Alaska Native insights, often you have to go through restricted data. And so when you look at then the PubMed articles, then it won't be as much. So lessening the transaction costs, or doing some kind of model where there is more access to data, and we can talk about that. I'm not a big fan of the model data piece, but thinking about ways of getting access to data is important, and lowering the transaction cost. And then capacity to invest in equity assessment, partnerships, and of course, accountability to the public. So I'm at 12:51, and I hope to engage in the next 10 minutes. I'm sorry.
Well, thank you. There's such rich information that you have had to share. So we've got several questions, and I'm just going to start with the first one that came in moments after you began presenting. Yeah. So this is from Amy Williams, who says that she is a UCLA MPH 2010 graduate. And she said Dr. Glick used to promote the CHIS regularly, so you know who that is. So she wants to know, how has the data collection changed since 2010 in terms of the data collection methodology?
Sure, and Grow Bruins, thank you. Thanks for that question. We, as I kind of talked about was starting in 2019, 2020, we did a big redesign in CHIS, and prior to that, we did experiments like, would this work, would this not work? So we moved from a CADI design, an RDD design, which is random digit dial survey, and a telephone interview, where industry-wide response rates were plummeting. I mean, response rates like single digit. And CADI is expensive too, because you have to hire interviewers, and then anyway, it's high labor costs for CADI. So we moved to an address-based sample, ABS, push to web, where then they would get a letter, have, as I explained, and have a website and log in and answer the question, on your computer. And for those who who would prefer by phone, there's a number for them to call. For those where we didn't hear from them, then we started getting the interviewers, after them, hounding them, like saying. And then I think it's about 6 times. We may have made it like 5 times, just because I start to get a lot of complaints.
I hear you. I think somewhere along the line, my husband got the invitation to go and do the web one. And of course, being a health services researcher, when I saw the return address, I was like, you have to go fill this out. So it is always, I think, fun for researchers when they have friends or family members, or they themselves are sampled, because then you feel like you understand how the sausage is made. And of course, you have an incentive to do it because you know how important these data are. Let's see, we have an anonymous attendee who has a relatively technical question. So it's okay for you to defer this, because there are actually a number of questions in the queue. The attendee asks, can you talk about how the non-probability based sample data are analyzed? Can you use post-stratification weights and raking to estimate the probability weights?
Yeah, I think that's kind of like what we did. So it's a great technical question. The non-probability was, so we actually went to the space, I'll try to do this very quickly, not into doing something called respondent-driven sampling, and where it's basically, it's a convenience sample, the seed, and then they tell us, they give us, it's like kind of a network, and they tell us who to go after, in the survey. And then those folks tell us, anyway, the more you build these seeds and grow them, then you get rid of the first seeds that was completely convenience, and it approaches a quasi-probability sample. That was our hope. We also drew from the California Health Interview Survey folks that identified as LGBT or NHPI, to get a sense of what was the probability piece that would help us with doing these post-stratification weights. So it worked okay for the LGBT, and actually it's not true. So the main CHIS does not ask questions on Q, but I think the follow-up did. NHPI, we could not do it. It was a fail. And then we started going into social media and to community groups. So we went to community groups, then we started going to social media with money incentives. Failed the first time because there were bots, mostly from China, that answered, because all of a sudden overnight, like we had 5,000 respondents. And we were just like, first we were just, whoa, it's a lot. But when we went through and looking at the URLs, so then we had to like go back to the drawing board and then really have, I forgot what those are called, Joanne, but like when you do the, CAPTVA, is how many traffic lights, how many motorcycles. So we started doing that, so it wasn't a bot. We have a yield of about 1,200 now. How is it being analyzed? We do have some weights. We are very careful to call it a probability representative sample, though. And this is just getting out now too, so stay tuned if you want to analyze this. So we haven't actually analyzed it yet for, I say, hypothesis-driven question, but it is going to be coming out soon this year.
Great, great. Is it fair to encourage anybody who has technical questions to take a look at the CHIS website and then to reach out to learn more about the technical details?
For
Great.
sure. Yeah.
Excellent. So there are a couple of questions that I also want to make sure we catch. I know we're running short on time. One is from Sepida Banava, who I hope I did not butcher the name too badly, who observes that intimate partner violence and domestic violence is an underestimated public health priority affecting all aspects of individuals' health. Evidence shows that race and ethnicity related inequities and disparities exist in this space. However, looking at the CHIS website, did not spot that it was included in the questionnaire topics. Is this embedded in some of the other topic areas? And if not, is there interest or potential to add it to the survey in the future?
Definitely interest. We've had IPV questions in the past that was funded by Cal Wellness. So we've had it. So part of it too is that, as I tell some folks, I feel like I sell, I have a bake sale every 2 years. Just is not all government. I mean, we get 60% from Department of Healthcare Services and California Department of Public Health, but the rest are, private foundations like California Endowment, CHCF, Cal Wellness, San Diego County. So it is like a baker's dozen of funders that we do this bake sale every year, every 2 years. IPV was not funded all the time. So there are some years, and you can email me, although you want, that wasn't an anonymous person, right? So you can email me, and we will have an IPV question, I think, this coming year. So there's some questions in ACEs that get at, it's not intimate partner, but any family or household, any family or household violence that has occurred. So, so I think that's, we will have that. And I agree, absolutely agree. We recently consulted with the Veterans Administration on, they're developing intimate partner violence questions. So we've also consulted with them, and we're trying to do something with to try to get at the Native communities and this concern about missing and murdered Indigenous women. So we've also in conversations with CDC on working with them on putting an IPV module.
That's great. We have faculty here who've been doing work on these issues around the Native American community, so I'm sure that they would be happy to learn that. If you'll indulge me with a couple more questions, I know we have you for a few more minutes.
Sure.
So Hal Left, who asked about whether there's any research that's been done broadly. I don't think this is a CHIS specific question on probing equity issues, not only about how individuals self-identify, but also how they perceive that others identified them. If somebody sees them for the first time, and what do we know about that kind of self-identification versus how people think that they are being perceived, and the discrepancies or the issues that may surround that?
Yeah, great question, Hal, and wishing you well. I'm actually going to next week, University of New Mexico conference on looking at street race. It's called Street Race. It's being held, the main scholar there is Nancy Lopez from UNM. I will learn more about that. I will share. Actually, one of the workshop goals is to identify all the data sets that actually have this question, because I'm thinking about putting it in CHIS, but I want to understand, has it been asked? How well, was there any cognitive testing? And what, where was this asked? So I am thinking of putting that in, and hopefully this workshop next week will give me more intel on that measurement.
Interesting.
Yeah.
Oh, let's see. So we have a question from Halimat Fa Yusuf. How do you differentiate between disparities from differences, the distinction between disparities and differences in segregated data?
I'm not really sure what segregated data means, but yeah, I know I glossed over health disparities very quickly. There's a National Academy of Medicine definition from what was, was called IOM, the IOM report on unequal treatment, with a model put forth by it's Tom McGuire, and Joanne, we went dancing with her and I can't remember her name, but she and it's just basically, it shows, it's a difference is not a disparity. So if you see a difference in outcomes, it might be due to preferences, it could be due to need, right? But a disparity then would be about any system-wide, healthcare system-wide factors, social factors, blatant discrimination and biases. So actually just also led a methodological session at Academy Health on this measurement, and how there's a bit debate in that preferences, though, are shaped by institutional. So even if you say, well, these are allowable because they're shaped, but because they're age, sex, preferences, but these preferences could be shaped by institutional. So I don't know. So I'm not sure I'm answering your questions. I'm not sure what you mean by segregated data, but it's, I think a lot of models that I run try to get at what's produced, by health system factors. And I do, even after controlling for race, ethnicity, if some of these outcomes continue, and these contextual factors, also bringing in multi-level models, that if these factors continue to persist. So I think it's partitioning, having good data that can help partition and parse out the different levels. So as you say, it could be, I'm even misinterpreting segregated data, because I'm thinking like, is it?
Yeah, the questioner just added to clarification. Okay. So the data that are kind of stratified by the different racial groups.
Okay. So this was also, so you can, the other thing is, I think with health equity, more and more, and I hear this a lot from, some of my colleagues, that you don't have, I don't think, I'm of the mind of, you don't have to compare, you don't have to, and plus comparison ends up being, what's the right comparator? Should it always be non-Hispanic whites? Maybe it could be the most privileged, but is it the most privileged socioeconomically, or the most privileged with the best health outcome? Should it just be the state average, the national average? So I think like the comparator group should be a synthetic, like aspirational, what should it be? So that's also under consideration. Segregated, stratified, I think you could, more and more, it's looking at one particular group, and within one group, looking at the different identities, intersectionalities within that group to better inform the kinds of programs and policies to target that group. So in the service of that group.
Well, thank you. I think we are at 1:05, so we've kept you a little longer than advertised, but thank you so much for taking the time today. It has been a pleasure to learn about this work. As I said in the introduction, the CHIS is a crown jewel, and as you can tell, Nunez has a combination of a deep understanding of foundational issues around racism, identity, social determinants of health, as well as this rich technical knowledge about how to do a really complex survey and analyze it and weight it and so on. So it really is actually not that often that we get to meet somebody who brings together this incredible technical knowledge with this deep theoretic knowledge. You can see why she is such a star and why we're so lucky to have Nina speak today. So this webinar has been recorded. It will be on YouTube. Yeah. The slides will be available. And thank you so much for being with us today.
I just remembered Anna Gomez.
Anna Gomez, that's right.
Yeah,
So look her up, everybody. Anna Gomez is pretty awesome.
She's pretty awesome. And just like one thing quick, we have a national network of state surveys because we try to share what we're doing to other states and other communities. So absolutely, we want to diffuse this. Thank you all. Thanks so much. Thank you, Joanne, for the
Thank you. Have a great day, everybody.
Bye-bye.